Good afternoon. We're going to get started in a couple minutes. We'll let people come onto the site, and then we'll begin our lecture today. Anybody have any questions they'd like to ask me? You can actually send these to me. Now, Dr. Cohen is not going to be here today. So at the end of the session, if there are Q&As that you want me to answer, I'll answer them at the end of today's session. So Dr. Kim asked me a question. It's a practical question. When there is a large lesion for melanoma on the face, would you reschedule the patient the next day or later do an excisional biopsy in the face? For a non-Mohs dermatologist, what would you recommend? Thank you. Angela, that's what this lecture is all about. And you'll see how my suggestions and how I evaluate and manage patients with melanoma on the face, depending on the size of the lesion, determines what I do. If in the clinics, it's a little tough because you're seeing lots of patients. So unless you can have a patient who has a lesion which you can then immediately send to someone who can do the biopsy for you, in those instances, you obviously do need to reschedule the patient. In private practice, you don't. That is, in private practice, it's very, very easy to do both excisional biopsies as long as you have the help to be able to manage that at that moment in time. And we'll go over that. And even if you're a non-Mohs dermatologist, in terms of the biopsies, you can do your own excisional biopsies. In my opinion, they're far better than either punch or broad shave biopsies. And we're going to go over this during this lecture. Now, that being said, I'm going to get started in just a minute. We'll wait to 12:05, and then we'll begin the lecture. Are there any other questions? Oh, no. What happened here? There we go. Okay. All right, so I'm going to get started. And today's lecture is the role of dermoscopy in the evaluation and management of facial lesions on sun-damaged skin. Now, it's a long lecture. I might have to go into two parts. Part one will be today, and part two will be the first or second week in January, the next time we meet. In the January issue of JAD is a CME on confocal microscopy. So for the other lecture in January, We're going to have a confocal microscopy lecture. It will either be done by Dr. Grant Kells or myself. And it'll be a good review for you because it is the CME article for that particular month. So let's begin with our lecture. Again, thank you, MedOptima, for hosting this. If you haven't been to their site, take a look. You're able to do mole monitoring. I get asked all the time in terms of attachments on your iPhone. They have a new attachment for not only iPhones, but iPads as well. So take a look at their website when you have a chance. Now, as a pretest, the most important color to diagnose melanoma on sun-damaged skin dermoscopically is 1, 2, 3, 4, or 5. Okay, so let's begin. This is from a 1975 dermatology text, and you can see it was called a senile lenigo. I don't think so. This is melanoma. And we certainly have made progress in the diagnosis and management of neoplasms on sun-damaged skin. This is melanoma. This is melanoma. This is melanoma. All of these are melanoma. Melanoma. It usually starts as this tan-brown macular patch, but can have a variegated pigmentation. And the early lesions are quite subtle. One of the clues to diagnosis is they are often isolated lesions to a particular quadrant on the face. That is, you have one pigmented lesion and nothing else. And those are that's probably the most important clue, is that these lesions tend to be isolated. Isolated lesion, nothing on that particular quadrant. Isolated lesion, isolated lesion, all isolated lesions. Subtle melanomas. All isolated lesions. Here you can see no other pigment. No other pigment surrounding this lesion. Now, if left untreated, when they get larger, they're tough, both not diagnostically, but at least treatment-wise. You can diagnose this from across the room, as well as this and this. But from a therapeutic point of view, in terms of managing these, the bigger the lesion, the more difficult it is to treat. This lesion is all melanoma. And this is the central portion, which was a invasive thick portion of that particular melanoma. Now, there are several non-invasive methods that we use to diagnose facial neoplasms. These include the Woods lamp. Okay, I don't use this at this particular moment in time. We have better devices. We have our dermatoscope, which is our workhorse, and the confocal microscopy, which is truly the Rolls Royce. Now, today we're going to talk about dermoscopy and its role in facial melanomas on sun-damaged skin, in making a diagnosis, the type of biopsy, aiding the pathologist in the histologic diagnosis and treatment protocol. Making a diagnosis. Melanoma on sun-damaged skin of the face must be considered in all isolated pigmented lesions of the face. Our next step is then to do dermoscopy, and if the lesion has one melanoma-specific feature, it should be considered for biopsy or at least for mole mapping or monitoring. Now, if the confocal is available, it too should be considered. So, our dermatoscope, our stethoscope of the skin, our workhorse, you know how it works. We've been through this, and I'm going to skip through this. This is normally what we see without the dermatoscope. Now, if we had alcohol, saline, or oil, place it on the lesion, and with the non-polarized dermatoscope, we can see features at the DE junction, the network, which corresponds to melanocytes at the base of the epidermis, and the holes corresponding to the papilla. The round structures are globules, which represent, as you know, the nests of melanocytes in the papillary dermis and the vasculature. And the vasculature differs depending on the neoplasm. Clinical dermoscopy. Clinically, this looks like either a a lentigo. And you'd pass over this every single day. With dermoscopy, though, it's a different differential because what we see here are great arch granules, which are the regression structures, and these gray circles, gray follicular openings. Now the differential is either a melanoma on sun-damaged skin or a pigmented actinic keratosis. So let's review the dermoscopy approach to diagnose melanoma on sun-damaged skin and other facial neoplasms. Some helpful clues. Flat pigmented lesions, as I mentioned before, isolated to one quadrant of the face acquired during adulthood. Consider melanoma. And it's very important. Any isolated lesion, isolated lesion, isolated lesion, isolated lesion, nothing else. Isolated lesion on the ear, isolated lesion. Two more isolated lesions. And what is the differential diagnosis? Well, the differential diagnosis for pigmented facial neoplasms includes a lentigo, a seborrheic keratosis, lichen planus-like keratosis, which, as you know, is the great masquerader, pigmented actinic keratosis, pigmented basal cell carcinoma, and of course, melanoma. On sun-damaged skin, sometimes not so easy to distinguish between melanocytic and non-melanocytic lesions. Melanoma, a basal cell, lichen planus-like keratosis. You can see they all have very, very similar features. And when subtle on clinical inspection, they can be even more difficult. Here we have two subtle melanomas. And this is where dermoscopy plays such an important role. Now, point number two is on sun-damaged skin, a characteristic pigmented network pattern is not found on facial skin. And this is due to the unique anatomical features of the face, the prominent pilosebaceous units and adnexal structures. Here you can see the flattening at the DE junction and a relative thin epidermis. So you normally don't see the follicular openings, you don't see the hair follicles. You have sometimes you'll see a more thickened epidermis than what you're seeing here. And you can see this tremendous sun-damaged space based on this relatively flat dermoepidermal junction. And so this results in two predominant patterns, the annular pattern and reticular pattern. In the literature, you'll see an entity called a pseudo-network on the face. I don't like that term. To me, we're looking at circles and lines. So I use a little bit of different language than you'll see in the literature. This occurs with flat pigmented lesions. So here's the annular pattern. It's characterized by small circles, follicular openings, surrounded by varying amounts of pigment. And here is an example with this lentigo. Here you can see the follicular openings, as well as you can see the pigment surrounding the sweat glands, and it accentuates these structures, forming circles and rings. So all you really see are these annular white circles, okay? There is no pigment at the periphery of the circle. And it creates what's called the annular pattern. Now, benign lesions are characterized by few colors, a relative symmetric pattern. And here you see two lesions which are benign. You can see the symmetry. Whereas malignant lesions are characterized by many colors, an asymmetric pattern, and great arch granules. And this has been called the annular granular pattern. So you can see the difference between a benign lesion and a malignant lesion. What lesions are depicted by an annular pattern? Well, we have a differential, and this includes the following: a Clark-Nevis, a solar lentigo, a seborrheic keratosis, and here you can see a couple of the comedone-like openings with this seborrheic keratosis, a lichen planus-like keratosis, and all you see are great arch granules in a pattern which we often see on the face, An actinic keratosis, it's characterized by these evident follicles, these open, widened follicular openings, and melanoma. What lesions are depicted by a reticular pattern? Well, a reticular pattern is characterized by fine, thin lines, short curve interrupted, and classic for this is a lentigo. And this lesion here looks no different on the face as well as other areas of the body. In contrast, a melanoma on the face with a reticular pattern consists of lines that are thin and thick. You have light brown, dark brown, and gray, and you have what are called angulated lines, which we spoke about for melanomas on sun-damaged skin on truncal areas. And here we have subtle lesions with angulated lines. These angulated lines, you can see, can form what are called rhomboids. Angulated lines. More angulated lines. Angulated lines. Now, we divide patterns of facial neoplasms into two categories, benign and malignant. And patterns that we see with benign neoplasms include ciliary lentigine, seborrheic keratosis, and nevi. And a malignant pattern could be seen in, obviously, melanoma, but then you have what are called the melanoma simulators. So let's take a look at a solar lentigo. The features include the circles with areas of light and dark brown, the so-called annular pattern, or a pattern which we see as a reticular pattern with a fine line, straight, slightly curved, long, short, and parallel. Borders are often well demarcated, scalloped, or mothy, no differently than you would see on truncal areas or on extremities. And here we have an example of a lentigo, again, where we see these circles or rings with areas of light brown and dark brown. You can see also the scallop borders. And this lesion here is the classic pattern, the reticular pattern, demonstrating the fine straight lines, the fine slightly curved lines, and fine interrupted lines. In this lesion here, it has sort of a wispy appearance, and you can see that it's characterized by these fine lines, straight, slightly curved, long, and short. An early seborrheic keratosis is characteristic of a lentigo with additional subtle features. So with an early seborrheic keratosis, the lines become thicker. That is, they're not fine, but they become a little thicker. You can have what are called bulbous projections, which are round circles projecting upwards. You can then get the ridge formation, and you can see a few milia-like cysts, and those are the white oval structures, the comedone-like openings, the slight invaginations, the brown keratin-filled oval structures. So here we have a early seborrheic keratosis characterized by these ridge formation and these bulbous projections. In this example here, what we see here is that we have these fine interrupted lines become thicker with early ridge formation. So you can see it has the pattern of a lentigo, but the lines are thicker. And this is an early seborrheic keratosis. Histologically, it's characterized by slight epidermal hyperplasia with compact orthokeratosis, an early seborrheic keratosis. Now, seborrheic keratosis is sharply demarcated or scalloped. You have white oval structures, the so-called milia cysts. You have the brown oval keratin-filled structures, the comedone-like openings. You have the linear keratin-filled structures, the fissures, and the ridges, the raised projected lines, the twisted loop or hairpin vessels, and fine vessels surrounded by a halo. There's no difference in the dermoscopy features on the face as compared to other anatomical sites with seborrheic keratoses. So here we have this lesion, and it has the classic cerebriform pattern. Right? You see the ridges and fissures or the so-called gyri and sulci. In this lesion here, we have characteristic features of a seborrheic keratosis where we see the numerous milli-like cysts. We can see these raised projected areas, which are the ridges. The depressed areas here are the comedone-like openings, and these linear depressed areas are the fissures, a seborrheic keratosis. In this lesion, we have the additional feature of seeing these twisted loop or hairpin vessels. We have the milli-like cysts as well as the comedone-like openings. Nevi. Most nevi on the face are raised, and the dermoscopic features are no different than other areas of the body. And the most common nevi on the face are congenital and intradermal nevi, or nevi with congenital-like features. Extremely rare to develop a new flat lesion on the face. That is, it's rare to develop a lesion as you get older, a junctional nevus on the face. It's also rare to see a melanoma in association with a nevus on the face, but occasionally you do. And here is an example of a melanoma in association with an intradermal nevus. And in this example, this melanoma in association with a nevus as well. When this occurs, the overwhelming majority are these are melanomas in association with congenital nevi, not dysplastic nevi. And that's very important. It's extremely rare to see a dysplastic nevus on the face. Occasionally you'll see them in the scalp, but other than the scalp, extremely rare. And if you get a report that comes back as a dysplastic nevus on the face, you must think melanoma. It's very, very rare to have a junctional dysplastic nevus, and it's very, very important to realize that. Now, the malignant patterns, a caveat. Not all malignant patterns are melanoma, nor are they all malignant. We have what are called the melanoma simulators, and a pigmented actinic keratosis and a lichen planus-like keratosis are melanoma simulators, as well as a pigmented basal cell carcinoma. So the classic features of melanoma on sun-damaged skin are the following, and we're going to go through all of these. And these are some additional features which we're going to talk about as well. So the first is slate gray to blue-gray dots granules. And this was the percentage in this study that we did a couple of years ago, where we looked at over 167 facial melanomas. And the most common were the regression structures. And here we have an example, subtle lesion on the face. Here you can see the regression structures. These gray dots and granules are regularly distributed throughout the lesion. Okay, and that's a melanoma in situ on sun-damaged skin. And this is a melanoma in situ on sun-damaged skin. And here again, you can see the regression structures. Irregular gray-brown pigmentation between the follicles. Here you can see that between the follicles, you have this irregular gray-brown pigmentation. And it's these aggregates of hyperpigmentation distributed asymmetrically between the follicles. And here you can see more examples. This irregular gray-brown pigmentation between the follicles. Angulated lines and rhomboidal structures. Here we can see what have been called angulated lines, dots and lines arranged in an angulated linear pattern, and occasionally they form rhomboids. On truncal areas, the melanomas on sun-damaged skin tend to form polygons. Angulated lines. Angulated lines. Angulated lines. Gray follicular openings or gray circles. Here you can see these gray follicular openings. It's gray to gray-brown pigmentation outlining the follicular opening. You can see how subtle that melanoma was. Gray circles, gray follicular openings. Here again, you can see some of the gray follicular openings. brown, brownish gray follicular openings, dark structureless areas obscuring the follicular openings. As the melanoma progresses, it obscures the follicular openings. And here again, you can see you have the follicular openings not easily visualized. Dark structureless areas obscuring the follicular openings. Circle within a circle. These are what are called circles within circles. Okay, and it's not a common finding. It's two concentric pigmented rings, but it's quite distinct for melanoma. Here you can see the circle within a circle, circle within a circle, and here as well. White shiny structures, these are the crystalline structures which you only see with polarized light. Here you can see in the form of these shiny white linear or orthogonal lines, which tells you that it's an invasive melanoma. Here again, we can see these shiny white structures. And finally, a blue-white veil, which makes your heart sink. And here you have such an example of this blue-white veil, this hazy confluent white area devoid of structures. Blue-white veils. Now, these are features that are more recent in terms of the literature. Increased vascularity in atypical vessels. Here you can see these polymorphous vessels. Their increased number of vessels relative to the background. Here again, too, you see these linear irregular vessels within the pigmented lesion. Multiple colors. Here you can see the multiple colors, the pinks, the grays, the area of black and brown. Multiple colors, 4 or more colors, multiple colors. Globules, extremely rare. Here we have an example. Globules are regularly distributed, not very, very common. And I've only seen this a couple times. White scar-like areas. Here you can see these scar-like depigmentation. These white shiny areas within the lesion at the periphery. And this is in the contact non-polarized mode. Here you have this white scar-like area, shiny white areas. A red pseudo network. Here you see this red pseudo network. We've only seen it once or twice. And it really throws you off because when you see this, this is often characteristic of pigmented actinic keratosis, is to have a red pseudo network. In this particular instance, this is a woman who had melanoma a couple times on her nose, treated with Aldera multiple times, which often will destroy the pigment and will give you this type of vascular prominence. Again, here you can see this red pseudo network. Now, can one distinguish the features of pigmented actinic keratosis from facial melanomas on sun-damaged skin? And so the answer to that is most of the time, but not all the time. Well, what are the features? Well, you have to realize that a pigmented actinic keratosis is a collision between an actinic keratosis and a solar lentigo. And this collision accounts for the spectrum of the clinical and dermatoscopic features observed in the lesion. So here you see portions of a lentigo, and here you see portions of the actinic keratosis. And it gives you these unusual patterns, which make it very, very difficult in terms of attempting to distinguish a pigmented actinic keratosis from a melanoma on sun-damaged skin. Well, let's take a look at the patterns. Probably the most important clue is not dermoscopy, but a clinical clue, because almost all pigmented actinic keratoses have a scale. And that's the most important feature to look for. And it correlates to what we see here as what I call these keratin bands. Okay, so the scale is these keratin bands or keratin lines, which really looks like a broken pseudo network. An annular pattern. And here you can see it's an annular pattern. Moth-eaten borders, because as I mentioned before, a pigmented actinic keratosis is a collision of a lentigo and an actinic keratosis. So you'll see features of a lentigo as well. Gray dots granules. Here you can see the gray dots granules. So the regression structures, as we've spoke about before, can be seen in both melanocytic and non-melanocytic neoplasms. Later on in the year, I will give you a lecture on regression structures. And it's one of my favorite lectures. A red pseudo network. Here you see a red pseudo network. This is quite common with pigmented actinic keratoses or actinic keratoses on the face. White circles are evident follicles. What this means is that the follicular openings within the lesion tend not to be obscured by pigmentation of any color, and they're prominent. You look at it and you go, wow, look at all those follicular openings. And this is an example, and we call these evident follicles. And as you take a look at this, you go, look at all of these follicular openings. Look at all these white circles. And that's characteristic of a pigmented actinic keratosis. And finally, rosettes. Here you can see these 4 points. Rosettes are common, not only in pigmented actinic keratosis, but non-pigmented actinic keratoses as well. And it's extremely rare to see rosettes in melanoma. Extremely rare. I've only had 2 or 3 cases. And something called an inner gray halo. You look carefully, there's this halo inside the lesion. This was described by the Brazilians years ago, and I've never been particularly impressed. Point number 9. Dark blue basal cell carcinomas clinically are almost indistinguishable from melanomas, nodular melanomas. So this is a basal cell carcinoma here, and this is a nodular melanoma. And the features that we look for pigmented basal cell carcinoma in the face are no different than anywhere else on the body. And these include the following. Here we have this clinical lesion, and here you can see these ovoid nests. We have these blue globules. We have white strands. Remember, with basal cells, they tend to have strands and blotches. In this example here, you can see the blue globules and the ovoid nest has a blue-white veil, which you can see with the melanoma, but you can also see these with a nodular basal cell. Point number 10, lichen planus-like keratosis dermoscopically has the following features. It has features of a lentigo or a seborrheic keratosis with focal gray dots granules, or diffuse gray dots granules, or gray dots granules following an annular distribution without additional melanoma-specific features. So here we have this subtle lesion on the cheek, and all you see are gray dots granules, nothing else. This is lichen planus-like keratosis. Or this lesion here, it's a little tougher because it's in an annular distribution, but there is nothing other than these gray dots granules. Here we have this lesion, and in this lesion here, we look for a clue. Well, we have our gray dots granules, but if you look here, we have some milia-like cysts and fine lines slightly curved. This lesion here is lichen planus-like keratosis. And we followed her, and 3 months later, you can see it's almost completely resolved on its own. Dermoscopically, you can see all the gray dots granules have completely resolved, or the majority of them. Now, I like to take an algorithmic approach to diagnosing facial neoplasms. We have this woman with this enlarging pigmented lesion. What structures do we see? We have gray dots granules, some moth-eaten borders, and perhaps some milia-like cysts. Are there melanoma-specific features? These are our melanoma-specific features, and the answer is yes, because we see these gray dots granules. Now the differential then, basal cell carcinoma drops out, and the differential then is melanoma, lichen planus-like keratosis, and pigmented actinic keratosis. That's our differential. So the first question we ask is there a scale to the surface? In this case, there wasn't one. In this instance, then, the pigmented actinic keratosis drops out, which leaves us either lichen planus-like keratosis or melanoma. And then you ask yourself, are there diffuse coarse granules? The answer is no, it's almost diffuse. Are there structures either of a lentigo or seborrheic keratosis? And yes, you see these mouthing borders and milli-like cysts. So melanoma drops out, and then you're left with lichen planus-like keratosis as your diagnosis. And here we have a lichen planus-like keratosis. Now in this instance, this nodule, patient said he had it for about a year. This is our differential. Here we see the ovoid nest, some globules, a blue-white veil, and are there brown dots in focus? I can't tell whether this is just ulceration. Are there melanoma-specific features? And the answer is yes. There's a blue-white veil. Now our differential now is different. The differential now is either a melanoma or a basal cell. It has features of a basal cell, which we spoke about, ovoid nest, blue globule, ulceration, and these are features that we see with basal cell carcinoma. And when biopsied, is a basal cell. Now, we clearly would manage this differently if we thought this was a nodular melanoma. We wouldn't shave across it, okay? You could theoretically do a punch, but you wouldn't shave across the entire lesion unless you were sure. So in this instance, though, I'm sure, and any type of biopsy can be performed to achieve the diagnosis and a basal cell carcinoma. Here we have two patients, 1 and 2. And here you can see dermoscopically their lesions. Now, the differential here is a pigmented actinic versus a melanoma. You have gray dots granules, angular lines with early rhomboidal formation. And this is our differential. And in this instance, we see the same, and we have the same differential. So let's see if we can tease these two out. The first patient is this gentleman, no history of melanoma, had this 15 millimeter flat lesion with a fine scale. And that's our clue, the fine scale. Now, the structures we see with contact polarization, we can see a few things. We have regression structures, we have rosettes, and I've mentioned to you before, it's very rare to see rosettes with melanoma. And we have this what's called the inner gray halo. There are some gray follicular openings. In the non-polarized mode, we see the same features as well as a keratotic plug. And a keratotic plug, again, more commonly seen in a pigmented actinic keratosis. So these are features consistent with the pigmented actinic keratosis. How do I manage this? Well, as I say before, I don't like to shave across these lesions from a cosmetic point on the face. What I'll do is I'll do an incisional biopsy over a broad area, and I'll ask for immunostains as well. So we do a broad incisional biopsy. We have our diagnosis with CD1A as well as with our H&E showing a pigmented actinic keratosis. And the way I manage this, and to me it is the treatment of choice, my most success for pigmented actinic keratosis with 5-fluorouracil cream. I'm looking forward to using a combination of 5-FU with the calcipotriene to reduce the time for this. And that's on my next agenda. And here we see 4 weeks following topical chemotherapy, and this is 8 weeks. But what about our other lesion? Very broad lesion. It's been biopsied multiple times. Here we see a different pattern. We see here are these angulated lines, these rhomboidal lines, and look over here, a gray circle. Okay, even though perhaps there might have been a little faint scale, this is melanoma on sun-damaged skin. And when biopsied, you can see with immunostains, with MOR1, we have a melanoma in situ. In this instance, Mohs surgery is performed, and this is the patient 16 weeks post-op. Now, there are clues to differentiate facial lentigome malignant from pigmented actinic keratosis. This was published a few years back. For pigmented actinic keratosis, the white and evident follicles, the scale and red color are most suggestive for pigmented actinic keratosis. For melanomas, the intense pigmentation, the gray circles and gray rhomboidal lines appear highly suggestive of lentigome maligna. The absence of evident follicles is characterized 72% of lentigome malignas and pose a full probability of lentigome maligna. Now, this is important, the importance of gray as a clue in facial lesions. And what they found is that it's the single most sensitive feature for the recognition of facial melanomas, and its presence should always prompt the clinician to perform a biopsy. So if you see gray, please do not spray. And this woman over a 6-year period had seen multiple dermatologists and a primary care physician who had frozen this multiple times. She got tired of seeing dermatologists, so she bought her own spray on Amazon. And this stuff you just can't make up. And this is her dermoscopy, where you can see the gray follicular openings, the irregular gray-brown pigmentation, and the confocal also characterized by dendrites is characteristic of melanoma. And incisional biopsy is performed, and you can see it's a thin invasive melanoma. Now, another important point is a laser-like cryosurgery can mask early melanomas. And we had this patient who 2 years prior had laser to this particular area and it repigmented. And you can see the features that you now know are characteristic of melanoma. The gray dots granules, the gray circles, the irregular gray-brown pigmentation between the follicles. And this is a small enough lesion where we perform an excisional biopsy. If I'm wrong, he gets a better cosmetic result than a big divot on his face. We ask the pathologist to step section through the block, as well as to do S100 and MOR1 stains. And here we can see the melanoma in situ, and it's really characterized much better with the immunostains demonstrating a melanoma in situ. And we're seeing an increased number of these because more individuals are getting cosmetic treatment for these, either with lasers. And in one study of 72 specimens, follicular involvement was seen in 95% of the specimens. And the depth of intrafollicular growth by lesion melanocytes was 0.45 millimeters. So what does that mean? So it means that the laser is not getting down to that particular level, because the erbium laser and the COT lasers, you would need to have such multiple paths that you'd have an unhappy patient from scarring. So before you laser, you might want to consider doing a biopsy to make sure that you're not dealing with a melanoma in situ. And it is my opinion that prior to a cosmetic procedure with all isolated pigmented lesions, you must consider a melanoma in the differential. Type of biopsy. Well, that was a question that was asked to me. Do you do a punch, a shave, a deep saucerization, or an incisional biopsy, or an excisional biopsy? And this was an article published quite a few years back by Dirk Elston. And the article was on biopsy issues. And he comments on lentigome maligna. It deserves special mention because the large size of the lesion often precludes complete excision. Well, years ago, we actually looked at our database over a 2-year period, and it was 21 patients. You can see the range of the size of lesions was anywhere from 4 to 30 millimeters, with a mean 10.2, which is big. And what we found is that the majority of these lesions can have excisional biopsies. So here we have this small lesion. The patient recently had an invasive melanoma, and he has this small lesion on his temple. Dermoscopically, it's suggestive of melanoma. We do an excisional biopsy, a melanoma in situ. This individual here had a pigmented blotchy area. He actually had a melanoma here years before. And what we can see here are these gray circles. So we do an excisional biopsy and narrow margins. And if it is melanoma 4 to 6 weeks later, we refer the patient for Mohs surgery with immunostains. And this is just from his excisional biopsy from 6 weeks prior. And then he was referred for Mohs. They take smaller margins, and the results are superb. This patient here, one of the problems that Dr. Elston comments is that misdiagnosis is common in small specimens because the lack of effacement of reedy ridges, areas of regression, and collision with non-melanocytic pigmented lesions, such as benign lentigines and pigmented actinic keratosis. So in this patient here, he had a melanoma, he had a lentigo, and a pigmented actinic keratosis all within the same area. Another important point is do not do punch biopsies unless you're able to have almost the entire or complete lesion, because the pathologist cannot see the architectural pattern. It's associated with a very high rate of false negative results. So if you look at the odds ratio of misdiagnosis, punch biopsy versus excision, the odds ratio is 16.6 as opposed to a shave. Shaves are good for making diagnoses. Shave is much better than a punch biopsy. And for misdiagnosis with adverse events, forget those punch biopsy. Look at those odds ratio as opposed to a shave. And the reason being is that here we have this lesion. If you biopsy it here, it's a congenital nevus. And if you biopsy it here, it's melanoma. And you can't tell, even with dermoscopy, the area, in my opinion, to do a biopsy with dermoscopy. Now, this gentleman here had this lesion over an 8-month period, and a 3 millimeter punch biopsy was read the following way. Mildly atypical lentiginous melanocytic nested proliferation. They recommend it be rebiopsied if there was concern. Instead of doing the 3 millimeter punch biopsy, do the appropriate biopsy to begin with. Here we can see dermoscopically a gray circle, and he has an excisional biopsy, comes back as melanoma in situ, and is referred for Mohs surgery. This woman had this frozen 4 times, and every time it was frozen, the pigmentation would disappear and then recur. Mildly atypical lentiginous melanocytic proliferation. She had a small little punch biopsy. Here we can see features of melanoma. She has an excisional biopsy, melanoma in situ, and she had Mohs surgery, and this is about a year and a half after her Mohs surgery. Now, Dr. Elston comments that an excellent alternative may be multiple small shade biopsy specimens that sample every color and morphology within the lesion, and they can be placed in a single specimen bottle to maximize the chance of correct diagnosis. I haven't done this before, but it might be an alternative approach. What we do, as I say, is we try to take as much tissue to give the pathologist a diagnosis. If it's a large area, we'll do an elliptical incisional biopsy, such as in this case. We'll take an incisional biopsy, make our diagnosis, and refer appropriately. Aiding the pathologist in the histologic diagnosis. Well, we know the findings of melanoma on sun-damaged skin. We see often atypical melanocytic hyperplasia at the DE junction, confluence of atypical melanocytes with these angulated nuclei. We can also see this cytoplasmic contraction with adnexal involvement. And here you can see this nesting with occasional pagetoid spread. And very often you'll have these confluent atypical melanocytes lining the basal layer on a sun-damaged base. Now, one of the problems is it's still difficult to distinguish lentigo maligna from sun-induced melanocytic hyperplasia. And confocal is great for that, but you have to at least realize that that is a problem. Some of the stains that are used for the diagnosis of lentigo maligna include MART1, MITF, and SOX10. And I'm not going to go through these now. This is a video lecture, so if you want to read about it, I'll let you go through it slowly by just turning the video on and off. And another immunostain that is used is the MITF. MAR1 is the most common one used. SOX10 is becoming a little more popular. And then there's a new stain which we have not used, which is called adenocyclase. So these are some of the stains that are being used. Treatment protocol. Surgical excision, stage excision, Mohs surgery, non-surgical interventions like imiquimod, radiation therapy, and the pie in the sky. Surgical excision is the mainstay of treatment, but there's a problem. And it's well recognized that wide local excision with even as much as a centimeter is often insufficient for facial melanomas on sun-damaged skin as opposed to other types of melanoma in situ. High recurrence rate, as much as 20%. And that then brings up the point of stage excision. It's called slow Mohs. It's thought to be the optimal treatment if you don't do Mohs with very low recurrence rates. If you look back in 1990, I published this with some of my colleagues on lentigo maligna, the use of rush permanent sections in therapy. So this is not new. It's just had a repopularization over the past couple of years. And there are various ways to do this. There's the square, pyramidal, contour, spaghetti. And as I said before, frozen sections are clearly better than no frozen sections or rush permanents. So here we have examples of the geometric stage excision. Then we have Mohs surgery, which to me is the treatment of choice for these lesions. So here's our patient who I showed you before, who had the excisional biopsy. Now this is 6 weeks later, he has Mohs surgery. This is stage 1. You can see with stage 1, he's positive. He's got a positive immunostain. Stage 2, he's negative. And then he has an immediate closure. And here's his 4 weeks post-Mohs surgery result. This woman here was diagnosed with melanoma in situ of the cheek. An excision by the plastic surgeon demonstrated positive margins. She was treated with Aldera for 6 weeks. She developed a brown macula adjacent to the scar, read as atypical melanocytic proliferation, and was further excised with a clinical margin. Dermoscopy wasn't helpful, and this is when we used confocal, and we confocaled the entire scar. And what we found is that with confocal, there were 2 areas which showed dendrites, here and here. So we did an incisional biopsy of this particular area. There are the dendrites. And this is what we did, and showed positive with both MOR1 and SOX10. And she had Mohs. This is stage 1, she was positive. Stage 2, she was positive. Stage 3, she was negative. And for these larger lesions, very often we take an insurance layer, send it for permanent, and then she had an immediate repair, and this is her 1-year follow-up. This gentleman here was a 75-year-old man, history of desmoplastic melanoma. He was recently diagnosed with this intermediate thickness melanoma on the right forearm, and then he comes in for a follow-up or a new patient, and he has this isolated flat lesion on his cheek. Now you can see already, you got some angulated lines and great-arch granules. Here you can see the confocal, it's melanoma. These are dendrites around the hair follicles. An excisional biopsy is performed. Patients referred to Mohs at a later date, and this is his 5 months post-surgery. This lesion here, patients had multiple melanomas, new lesion, 5 millimeter pigmented macula on the cheek, angulated lines, dendrites around the hair follicles, excisional biopsy, melanoma in situ, and this is 1 year post-Mohs surgery. Then we have the non-surgical interventions, the imiquimod, and imiquimod has been used as an alternative, and there are studies which show that for primary cases, the cure rates are about 72%, and it's actually much better if you use it as adjuvant. That is, you're removing it, and then you follow it with an adjuvant course of imiquimod, higher cure rates. And but you have to realize that, to me, surgery is the treatment of choice unless it's a patient who is older, elderly, or poor surgical candidates. And in my opinion, one just has to be very careful. We've used it in a patient like this, 95, we're not going to do surgery. This is before showing you the melanoma in situ. And this is 16-week course of Aldera. This is 1 year later, and it's completely resolved, both with confocal and histology, just shows solar elastosis. Radiation therapy, it's another alternative. The cure rates are about 90%, and here you can see an example of radiation therapy working. And the cure rates are about 89 to 90%. And finally, the pie in the sky. Go on the internet, you'll see turmeric, all these other treatments. And then there's the role of cannabinoids. Is that a pie in the sky? We actually had a patient, a 67-year-old man, who saw a dermatologist for 2 lesions. One was a basal cell, the other melanoma in situ, and squamous cell. And he decided he did not want to have rush permanence by his dermatologist. So he himself concocted his own cannabinoid oil, and he made it from scratch. And this is how he made it: took the plant, crushed it, used a solvent to filter it, and he made his own cannabinoid oil. And there were little drops, and he placed it on his skin for 4 to 6 weeks. And then he's referred to me for evaluation. And when I saw him, this is the picture from his referring dermatologist, because he didn't know where to biopsy. So he referred to me for dermoscopy and confocal. This was our picture. Absolutely nothing. Dermoscopically, there was nothing. And confocally, this is normal confocal, in contrast to abnormal confocal. And the patient had a biopsy, which came back as a scar. So we're going to stop here. And when we resume in January, we're going to have a whole session on facial unknowns. I think there was only one question. Let me see if I can answer that. Where are you? Question. More. Nope. Are there any questions before we stop?
Yeah, so Dr. Benovitz, there is one question. It is from Dr. Rambia, and it's, how do you distinguish between red pseudo network and polyclioderma of CVI?
So what happens is that the red is within the lesion itself, as opposed to the areas around the lesion. And in the lesion itself, the color is clearly different than the pattern that you would see with a vascular component outside the lesion. And poikiloderma savata is clearly different. You really don't see that on the face. It's more predominantly on the neck. But you have to realize that it's within the pigmented lesion itself. All right, I'll see you in January. Everybody have a great day and happy holidays, and everybody be safe. Thank you.